we're looking forward to it, and I'm hoping that we, get to hear some of your valuable inputs on this subject, which is actually quite, if I have to put it across, I think it's a quite complicated situation when most of us come across, especially when we are trying to diagnose stuff. Our panelist here, I think we don't need to introduce her. I presume we all know her from when she was at the GDP. I think she's an esteemed endodontist who's currently practicing in Kuwait, if I'm not wrong.
Yes, thank you so much.
Fabulous. She's won quite a few awards from what I've received here, and she's also presented a few questions about, is it about ergonomics in dentistry?
Yeah, I was, that's long way back when I was doing my post-graduation.
I think that's something we all need to get acclimatized with, especially with ergonomics. I think chronic back pain is one of our biggest issues. Well, I'm really sorry. Yeah. It's very early in the morning here for me, but without undue delay, I think I will pass it back on to our speaker, Dr. Karobari. It's all yours. Take over, please.
Thank you. Thanks a lot, Dr. Ali.
Thank you. I'm going to mute myself.
Oh, please. Is it before you mute it? Is it all clear, right? You can hear it. It's audible.
Yeah, everything's perfect. Everything's perfect.
That's great. That's
all good.
Let me just share the screen as well.
Please do. I request. Sorry, one last thing. I'd request all participants to mute themselves, please, except for the speaker.
The screen is clear. Okay.
Yes, please start.
Okay. Very good morning to all of you, and assalamu alaikum. Probably, I think it's morning for the few people, quite early morning. It's here at 5 minutes past 2 p.m. It's post lunchtime. Great. Our induction has been given by Dr. Ali. I'm very thankful for that, and thank you, Dr. Ali, to be on board, and thank you, Dr. Sultana, to be on the panelist. It's great to have you. And I would like to thank Dr. Gausia and Dr. Firdaus and all of their efforts and all, which make us come on the same platform now to share the stuff. Today's topic is quite small. And before that, I could just let you all know I'm talking to you all from a small place called Kota Bharu, which is the capital of a state in Malaysia, Kelantan. Maybe many of them doesn't know what Kelantan is situated. To make it easy, you all know Thailand. So I'm at the border of Thailand. If I drive 20 kilometers from my university, so I would reach Thailand border, wherein we can have just, to be a privilege being an Indian passport. They just give us a visa on arrival, wherein we can just get in the Thailand and get back. So yes, I'm in a university, University Saints Malaysia, wherein I'm attached as an full-time PhD research fellow, continuation of my master's. In the same university, University Saints Malaysia. It's a government university. It's a public university. So let us come into the topic. Today's topic is we will be discussing about the well-known existing classification given by Vertucci classification, and we'll be comparing with the new system which is put in by Dr. Ahmad et al. He's one of my supervisors, Dr. Hani, which has been taken up in 2017. To start off, we'll have discussion in brief. I'm just giving a brief discussion how it varies and how Vertucci came in, and we have a new system. We'll compare it with the existing classification, Vertucci classification system. To be a practitioner, any practitioner or any GP or endodontist who would like to perform a root canal treatment will always have a thing that they need to have a perfect treatment approach to overcome all the treatment failures, and we want to achieve a good root canal treatment. So to effect root canal treatment, one who have to achieve a good root canal treatment, a good outcome of root canal treatment should have a perfect and complete thorough knowledge about root and root canal morphology. So unless you don't diagnose, you don't have a proper knowledge about the anatomy, existing anatomy, and the variation, the normal and the variation, and as well as the anomalies, will make you easy to diagnose and go ahead with the treatment. So then we can have a good root canal treatment to overcome the failures and to have good prognosis. That's what one want to achieve. One want to perform a root canal treatment is just to achieve a good treatment, and anyone who want to perform it, he wants to keep it perfect, and there's no failure in the root canal treatment. So that's how. So you should have a thorough knowledge about the root anatomy and the canal anatomy. In the year 1925, as in Jorel, they put up a study and classical work done on this, and they come up with a thing that we need to have a proper classification system. To have a knowledge about existing root and root canal system or configuration morphology, we should know the system to classify in different types. Like the way if someone wants to have a work done or something to categorize, we usually categorize in different division, different classes, different types. That's how one should have a classification system to classify root anatomy. That's how they make the researchers to work on it and to come up with the classification systems. The very old and well-known system which is used, the Vertucci Classification system, is given in the 1974 by Vertucci et al., wherein they come up with the 8 types. Before this, there's the system given by Venice et al. The year 1962 and 1989, wherein they gave 3 types, basically type 1, type 2, type 3. Later on in the year 1982, they add up one more type to the existing 4 types. So it's not much used nowadays, but still a few of researchers, they compare and they use Venice classification as well. But we were talking about the Vertucci classification system, wherein they give 8 types. Let me have a brief about the each type. I think you all well know, many of them are academician and the students and all, they want to postgraduate, so they'll be knowing Vertucci classification. So type 1, what is type 1? How the Vertucci describe the type 1 depending on the extent of the root canal from the root apex, the coronal part to the root apex. They describe type 1 to be a single canal starting from the pulp chamber, ending at the root terminal with a single foramen. That will be type 1. So type 2, they describe type 2 as starting as a two canals, separate canals from the pulp chamber. When they go to the root apex, they merge to become a single canal. So it's 2-1. Type 2 will be taken as 2-1. Coming to the type 3, initially it starts as a single canal from the pulp chamber. During the course in the canal, due course, it divides into 2. Later on at the terminal, it joins to become a single canal. So it's 1-2-1. Type 3 is taken as 1-2-1. Type 4 is quite straightforward, starting as a 2 canal, ending with 2 at root terminals. So it's overall 2 canals throughout the root. So it is type 4. Coming to type 5. Type 5, it will start as a single canal at the pulp chamber, leaving the pulp chamber, and due course at the apical third, at the root terminus, it divides into 2. So it becomes 1-2. So this is considered as described as type 5 by Vertucci classification. Coming to type 6, it starts at 2 different canals. Due course in the canal is joined to become 1. So it is 2-1. Later on at the root terminals, it divides again to 2 different canals. So it is 2-1-2. It's considered as type 6 by Vertucci classification. For the mode division, type 7, it states as starting a single canal, dividing into 2, joining to become 1. Later on at the terminus, it's again split to 2 different canals. So it's 1-2-1, taken as type 7. Type 8 is again straightforward like type 4. Start at 3 canals from the pulp chamber and as 3 canal in the 2 terminals. So overall, it's 3 canals throughout the root, is considered as type 8. So far it's clear. I think hopefully I'm not going fast enough. So it's quite clear. The Vertucci has given classification in 1974, wherein they come up with the 8 different types, starting from type 1 to type 8, depending on the extent and the extent of the root canal from the root chamber to the root terminal. So later on in the year 2004, the 2 authors, Certain Bailey, took almost 2,800 samples of permanent maxillary and mandibular tooth, wherein they did the root canal morphology evaluation. They found different types. I mean, some more types of variation, which has not been seen in Vertucci classification. So they added a supplemental type. So it's called supplemental configuration to the existing Vertucci classification. So existing is already, we have 8 types, wherein the Certain Bailey had added in the year 2004 15 type to it. But the literature, they mentioned the literature has 14 types, so we maintain as 14 type, but when you see the number, it's 15, starting from type 9 to type 23, wherein they continued the type from this classification from type 8, so on and so forth, from type 9 to type 25, a different supplementary configuration given by Vertucci. Okay, so the type 9 is again starting as a single canal. At root terminals, it divides, split into 3 different canals, so it becomes 1-3. Wherein they described as it type 9. Type 10 starting as a single canal. Due course in the canal, it divides into two. In the terminals, before terminals, just before the terminals, it divides into three, splits into three further. So it becomes 1, 2, 3. Later on, adjoins to become 1 and the one other existing one. So it becomes 1, 2, 3, 2 is type 10. So on and so forth. They divide different types. Like type 23 will starting as a 3 canal, but it becomes 4 at the root terminals by 1 canal divides split into 2. So it becomes 3, 4 taken as type 23. Okay, so far we discussed about the Vertucci classification. They came up with the 8 types. Later on in the year 2004, certain belly added supplementary type to the existing one. It becomes 23. Total now we have Vertucci with supplemental from type 1 to type 23. Hope it's clear so far. So let us discuss about the new system. Okay, the new system given by Dr. Ahmed et al. As I mentioned, Dr. Ani Ahmed is one of my supervisors for my PhD project as well, and we have been working on this since 2017. Still, we are going on. We have different projects on the root canal system and root canal classification system, and we are working on it for my PhD as well. So how exactly this new system, the new class system, works on? For easy of the operator, you can use any of the system for the tooth numbering. It could be universal, FDI, Palmer, anything like that. So we use here TN as a tooth number, the tooth number which you are classifying in, and we have two superscript number. One is before the tooth number, and one is after the tooth number. The number superscript before tooth number will tell you about the number of roots. That will represent the number of roots. If the example you mentioned is A1, it represents the one root. Okay, and TN is the tooth number followed by the superscript number, again the root canal configuration, which will give us different stages starting from the orifice, throughout the canal, and at the foramen. So we mentioned it as OCF. I'll be discussing with some examples which will make it easier. So we have an example of a single tooth here. We took example of a 3-4 lower premolar, where it describes as a single root. You can all see it has a single root, so it is given superscript number before the 3-4 is 1, that represents the number of roots, as it has one root, and one canal. The superscript post following the number is 3-4 is 1, that will represent the canal. So it becomes 1-3-4-1 is the code for the classification of lower premolar, the first premolar. Another example of same tooth, lower first premolar, wherein we have a different variation in the canal, but it has single root. So the superscript number before the tooth number 3-4 represents the number of root, that is 1. So it has got single canal followed by 1-2, starting as a single canal at the orifice. Later on, the due course in the canal it divides into 2 with the 2 foramens. So it is denominated as 1-2. So the code classification for this tooth becomes 1-3-4-1-2. Further configuration, same tooth taken as 3-4 lower first premolar, wherein we have a single root followed by the variation in the root canal morphology, that is starting as a single canal at the orifice. The due course in the canal it divides into 2. Later on, at the root apex it joins to become a single canal, so it's 1-2-1. The code will be for this first premolar will be 1-3-4-1-2-1. Excuse me. So on and so forth. I have some more example for single root tooth. Like this, the first one is like a single root with the variation in the canal, starting as a single canal. Due course it divides into 3 different and joins to become a single canal at the root of a single foramen. So it is 1-3-1. The another example is starting as a 3 canals at the orifice. In the due course in the canal, it joins to become a single with a single foramen. So it is taken as 3-1. So 1-3-1. So on and so forth. The last one is having 3 canal initially in the orifice. Later on in the due course canal, it divides into 4 canal with the 4 foramens. The one we have it at the type 23 in supplementary type by certain berry. It is 1-T1-3-4. So now we discuss till now we discuss about single. Now let us discuss about the two roots. So same as I mentioned, the superscript number before the tooth number will represent the number of roots. So now we have 2. So we mentioned the 2 here, followed by 2 different root we have to mention as different root, right? R1 and R2. Now we are taking an example as R1 and R2. It could be like mesial, distal, so on and so forth. So now we are taking an example as R1 and R2. Again, the superscript number, the configuration for each tooth. Hope it's clear, right? Okay, now let us discuss with few examples with the two roots. One, we've taken as the first premolar here, maxillary first premolar, 1-4. The superscript number before the root tooth number 2 will represent the number of roots that we have. Two roots here, buccal and palatal. B represents the buccal root, P represents the palatal root. So it's 2, 1, 4. So now the first root R1 is B, buccal root with one canal, and P is the second root R2, which represents the palatal root with one canal. So the code and the classification for first upper premolar for this is 2, 1, 4, B1 and P1. Okay, buccal root and palatal root. Clear? Okay. So you would have seen some cases wherein the division, the bifurcation of the roots will be only in the apical third, which is not considered as absolute roots. The way we had the example earlier, these are two different absolute roots. You know, the buccal root is different, palatal root is different. Whereas this lower incisor, the example of the lower incisor here, you can see the bifurcation is at the apical third, wherein it splits become two root, buccal and lingual root, which is not the absolute root. So in such cases, in such tooth, will superscript the configuration as 1 following the tooth number. So it's 2, 3, 3 is the lower canine. Okay, the two roots, 3, 3 lower canine, but the root bifurcated before the I mean not the absolute bifurcation. So we call it as single canal. We take it as single canal. Later on, bifurcation with buccal and the lingual root. So in this case, we mentioned 1, wherein we did not mention 1 here. We just mentioned buccal 1 and palatal 1 root. Straight down we went to the root because it's the absolute roots. This is just bifurcation in the middle third. We mentioned a single canal. Later on, at the apical third, it divides to become buccal and lingual root. So it becomes B1 and L1. As I mentioned earlier, so it could be any number of roots. So we just mentioned N as example of 1, 2, 3, 4, 5 roots, and so on, like R1, R2, R3, so on and so forth. How many roots you have, like mesial, distal. In case of maxillary molars, you have multiple roots, so it can go on, so on and so forth. So let us talk about some multiple roots. We discussed about a single root, double root premolar, and now we're going to the 3 roots molars. The example of here is upper first molar. As I mentioned, the 3 superscript number 3 before the root number will indicate the number of roots. So it has 3 roots. MB represents the mesiobuccal root, DB will represent the distrobuccal root, P is the palatal root. So MB R1, DB R2, P1 is R3, mesiobuccal, distrobuccal, palatal root. So 3 root, 1, 6, followed by mesiobuccal root with single canal. So it's taken as 1. Distrobuccal with single canal, DB1. Palatal with single canal, so P1. So it becomes 3, 6, 1, MB1, DB1, P1. Hope I'm clear. It's not getting confused, right? From root 1 to root 2 and root 3. Because this online, so I cannot interact with the people. I don't know. Hope I'm going slow enough and you all are understanding the difference between single, double, and 3 roots. Okay, so clear so far. We discussed about the Vertucci classification, wherein the Vertucci are given the classification as 8 type initially. Later on in the year 2004, certain Berry in the Turkish population, they added the supplementary types to the existing Vertucci classification, which is type 15 types. So now total altogether, Vertucci with supplementary, it becomes type 1 to type 23. Type 1 to type 8 Vertucci, followed by type 9 to type 23, the supplementary given by certain Berry, total 23. So now later on we discuss about the new classification system given by Ahmed et al. In the year 2017, wherein we use a single code with the tooth number, a superscript number before the tooth number, a superscript number after the tooth number. Superscript number before the tooth number will represent the number of root to the existing tooth, followed by a tooth number is 1, 2, 1, 3, 1, 4, 2, 1, 2, 3, 2, 4, 2, 5, 3, 4, so on and so forth. So the superscript number after the tooth number will represent the canal configuration starting from the orifice of the canal, duration of the canal, and the foramen. So clear so far. So now let us discuss with some cases what we have done in the clinic here, and we'll compare the Vertucci classification with the new system given by Ahmed et al. So you can see a case of here 2.5, wherein the tooth is 2.5. We can see the type given by Vertucci classification is type 2, which can be classified using a new system by 1, 2, 5, 2, 1. The type 2 of Vertucci says starting at the 2 canal in the orifice and at the terminus it becomes joint, become 1, so it's 2, 1. So in new system, it says as 12521. Okay, another example of a lower lateral incisor, a 4-2, wherein you can see it is showing a type 3 starting as a single canal, divides to 2 and joins to become 1 at the root terminals, that is 1, 2, 1. And we're using a new system we can classify as 1, 4, 2, 1, 2, 1, starting as a single canal, dividing to become to 2, and later on it joins to become 1 with one foramen. So it is 1, 2, 1. Let us compare this I discussed already in the previous slides, like wherein we have a 2 absolute root and 1 without root. This is the maxillary first premolar, wherein this Vertucci classify this both the premolar as type 4. It takes the premolar with 2 roots as type 4 and without single root also type 4. Where we can make out here, the Vertucci fails to describe the number of roots. They describe only the root canal morphology. They don't describe the number of roots, which can be described or classified using a new system. As I mentioned for this already, 1,4, it's 2, 1, 4, B1 and P1. The code for the root the tooth which has got 2 different root, buccal and palatal root, as taken as B1 and P1, 2, 1, 4, B1, P1, right? In the case of premolar, which has got single root, the same premolar, first premolar 1, 4, with single root is taken as 1, 4, 1, 2. So you can see the difference between Vertucci and the new system here. Vertucci takes both the tooth as type 4, wherein they fail to describe the number of roots, but new system classifies it as differently because of it has different 2 root and this has single root. So it is 2, 1, 4, B1, P1, and this is 1, 4, 1, 2. It has 1 root and he has 2 root here. Clear? Okay, another example, as I mentioned earlier, bifurcation at the apical third, wherein it divides to become buccal and lingual in case of lower canine. So we're taking an example of lower canine here, wherein the Vertucci describes it to be a type 5, wherein they again did not describe the bifurcation of the root or the division of the root with 2 different roots. So new system given taken as 2 roots, 3, 3 is a lower canine with single canal till the apical third. Then later on it becomes B1, L1, buccal with single canal, lingual with single canal. So it's 2, 3, 1, 3, B1, L1. Okay, let us talk about the lower first molar, where it has got 2 canals in the medial. Then Vertucci describe this to be a type 4 in mesial root and type 1 in distal root. Then they classify differently the different root. So M1 M mesial root becomes type 4 and distal root becomes type 1. You can give a single code using a new system is as 2, 3, 6 M2 and D1, because mesial has got 2 different roots, 2 different canals starting as a apical and going to the 2 foramen. So it becomes 2. So 2, 3, 6 M2 D1. Mesial canal with 2 and distal canal with 1 canal. Distal root with 1 canal. Okay, this is the case then in the clinics here. Example is upper first molar 1, 6, wherein they have 3 roots: mesiobuccal root, distobuccal, and palatal root. Wherein the Vertucci class is described to be as mesiobuccal type 1, distobuccal type 1, and palatal type 1. But in case using a new system, it can be given a single code as 316 MB1, DB1, P1. Mesiobuccal with single canal, distobuccal with single canal, and palatal as well with a single canal. So 316 MB1, DB1, P1. Okay, another a bit complication. I mean the complicated root canal morphology in the mesiobuccal root, wherein Vertucci describe it to be a maxillary first premolar with mesiobuccal root having type 2, distobuccal and palatal having a type 1 canal configuration. Wherein using a new system, you can just give it a single code 316 MB21 starting as a 2 canal, in mesiobuccal root starting as a 2 canal. Do course in the canal joins to become 1 with 1 foramen, so it becomes 2, 1. So it can be taken as MB21, distobuccal with single and palatal with single canal. So it's 316 MB21, DB1, P1. Another example of a lower molar, lower first molar, wherein you have a furthermore variation in mesiobuccal. It can be taken as 3, 6 with mesial and distal roots having type 15, and distal is having type 1. It can be used simply, can be given as a single code 2, 3, 6 mesial with 3, 2. Initially starting as a 3 canal, later on 1 joins to become 1, the other one is a single canal, with the two foramens, so it becomes 3-2. Distal canal with 1. So it's 2-3-6 M32 D1. So 2 roots, lower first molar, mesial with different variation 3-2 and distal with single canal. A bit more complicated case. Hope you all can see a mesiobuccal root in this case. A mesiobuccal root of the upper first molar, wherein you can see the variation in the root canal morphology has not been described by Vertucci. It doesn't exist in the classification of type 1 to type 8, neither in the supplementary given by certain Bailey till type 23, which can be classified using a new classification system quite easily. When we give it as a mesiobuccal, starting as a 2 canal, joined to become 1 with 3 foramen in the apex. So it is 2, 1, 3. As usual, the 3 roots, 1, 6, mesiobuccal. I showed you the description of mesiobuccal, which is not been classified using Vertucci, which is non-classifiable. There are studies have been done, certain studies have been shown that, including a study has been done in Malaysian population as well, wherein they found a lot of non-classifiable types by Vertucci, which is classified using a new system. And I'm working on few more populations from Saudi and subpopulation from Saudi as well, wherein we found few of non-classifiable types we found in that, which is under process of publication. So again, the distobuccal is 1 and parietal 1 as usual. So it's 316 MB, 213 DB1 P1. Mesiobuccal with 213 and distobuccal 1, parietal 1. Thank you. Thanks a lot. These are the few references what we use for the presentation. These are the few of publication of mine the last year, 2021. Thank you. This is my contact details. If someone you want to contact me for discuss further things and all anything, these are my email IDs and some social links and all, and the WhatsApp number. Thank you. Thanks a lot.
Thank you, Dr. Karobari. Can I ask yourself to come back on the video, please?
Okay.
And could I ask Dr. Saiyed
my video was off.
I'm sorry, now you've turned it off. You need to come back.
Oh my God. Okay.
So we
I
got
thought it's working, it's on. I didn't notice that it's not working actually.
Yeah, well, now it's working. Well, thank you.
Okay.
Thank you for your lovely talk. I think it's an extremely confusing topic for me. It's never worked. I'll be honest with you.
I tried my best to make it simple, to make it short and simple, you know.
It is a lot to take in, to be very honest. It's a lot to take in. Dr. Saiyed, what's your opinion about the talk, please?
For me, see, after my post-graduation, this is like the first time, I'm actually going through root canal morphology and stuff. So for me, I knew that there is this classification, but I did not go into the depth of it. But yeah, when Dr. Gausia told me that this is the topic, so I just went through the articles. And compared to the previous classifications, definitely this one is much, much easier. There is no memorization. You can apply it clinically. You don't have to, memorize those Roman letters which you have for each classification, vertices and its supplements. It's difficult. Yeah, we might memorize it as students, when we have to give our exams, but later on as a practitioner, for me, like, I'm not into academics, I'm a clinician. So it becomes very difficult. And if you have to ever document and stuff, you're Googling, okay, this is type blah, blah, type blah, blah. Yeah, that's a fact. But in this one, it's very, very easy. You don't have to memorize anything. Just know the tooth number, the root canal, and the root canal morphology. So it has easy application. This is what I feel.
Brilliant. Thank you. Any conclusive words, Dr. Karobari? Would you like to conclude your talk with anything for us?
What I could conclude best from my side has been told by Dr. Saiyed and Dr. Sultana. That's what, as we all know, the necessity is invention, the mother of invention. So as if even if you ask me, suddenly if I ask any one of you and say what is type 23 or type 21, type 16, you could sometimes I could go back and say I have to think about it. That's the only thing which we need to remember all the types. That's what the classification usually comes up with. You need to memorize all the types in Vertucci, then supplementary given by them. A lot of confusion and all. So the easy way is to make it easy for the student, for implementation, clinical implementation, the research especially, because when we work on different morphology and anatomical variation, we have a lot of variations. So this can turn up with a lot of statistical variation, statistical analysis and all. It's quite easy to make you just see what you see. You write it as a code. That's the classification of the tooth, right? You don't have to remember and make a copy of it. It's quite easier in case of documentation. It could be easy in case of communication between the faculty and the students. There's a lot of positive points which make them come with the different things, and we still are working on it to make it easy. And we are working on an application of it to be in academic side. We're working on the application of it to be in the clinical side. We do have a coming up the project. We're working on microcity right now. Hopefully, in some due course of time, we come up with some new application of it as well.
So, if I have to put it in a simple sense, you did mention about what you see, you write. I presume Vertucci probably did it in that manner, but I presume the newer classifications, they do expose patients to CBCTs in order to.
No, there a lot of studies have been done wherein they have gone with the conventional radiograph as well. But yeah, I agree. You need to repeat. Sometimes you need to change the angulation and take a periapical radiograph. As I've shown the few of the cases, we have done only with the periapical radiographs, wherein we did not see the CBCT. We didn't use CBCT proper to have a type 3, some type 4 cases, some lower canines and some premolars, wherein we did not use CBCT as proper assay. But I agree to you. We may have to expose patient to 2 or 3 periapical radiographs, right? But we do have other types wherein they saw sectioning of the tooth. They did a staining of the tooth. A lot of interventional technique has been used earlier to type. Even the case of certain bed in Turkish, it's kind of intervention again in case of research, wherein you need to section it, slice, stain it, and all, right?
Are we ready for the questions?
Please.
So the first question we've got is, I think it's from Dr. Nair. What is the need for such classifications and how would they influence the treatment approach? If I could put that question across to Dr. Saiyed, because she's a clinician and she's probably in a better position to answer that. So if
like I already said, that question is already being answered from what I said previously, because I was reading the question, so I knew that would be the answer and I gave it beforehand.
Oh,
but anyways, it's
because I was just chat. Can we see the question?
I keep myself aware of what's happening.
It is on the chat. It is on the chat.
Okay.
It is come up for everyone. So yeah.
Dr. Sultana, please. Yeah.
Sorry,
okay.
Dr. Sultana.
Yeah. So if we know the canal configuration, the number of roots, what we are treating, definitely our results, the outcome that we get, it's going to be much better. And in this, if you know the root canal and the root canal morphology, and this starts from where? It starts from the first thing that we do, the imaging. Usually we go with the 2D. So we can read, we can take angulations if needed. And very, very rarely in some cases where I feel that, the tooth has a complex anatomy or something, I would ask the patient to do a CBCT. So the first thing, what you're supposed to do. Secondly, when you start working clinically, your hunt for that particular root canal morphology that you're looking for, it begins right from the axis cavity. You go by the dentinal map. When you do the axis cavity, you use your DG16, your ultrasonic chopping, etc., to see what you are looking for, because you already have the root canal morphology in mind. And then with the use of magnification, illumination, etc., you get better outcomes. So in endodontics, basically what we are looking for at the end of the day is that we get desired outcomes so that we have good prognosis and successful treatment for the long run. So this is how it works. Yeah,
absolutely. I just want to add up to this, you might have seen Dr. Saiyed, many of the times when especially the PGs, when they work on, when they take the radiograph post-operatively, post-obturation, you'll find the variation. In many of the cases, we go through this, they find it post-operative. When they try to take a post-obturation radiograph, they found that the canal is missing. There have been studies that have been done in American population in the year 2005 by Hayes and all. They found that the failure in the root canal treatment is because of the missed canals. They found 15 to 27% variation in the root canal treatment failure is because of missed canals. So at that point, I want to add to Dr. Said, she's absolutely right what she said. Precaution better than cure. At the stage of the diagnostic state or where you want to analyze it. In that case, to overcome this, we may take some different angle, IOPAs and all, to overcome the variation. And a lot of studies available where we can make you cautious before you start the treatment, like in different ethnic variations. We have found like India, China, Turkey, many variation in populations. Ethnic variation has been seen in root and root canal morphology. So we need to be very careful before starting the treatment.
True. So I think the pre-op assessment with imaging is invaluable in this case. And especially what Dr. Saiyed said is the outcome is what we are looking for. Despite all that, it's not 100% successful.
Yeah. We try to give our best.
Absolutely, absolutely. We are positive. We've all had failures. We've all had failures, but you know,
it's taken a human error nowadays. It's not like doctor's fault. It's like human error nowadays.
It's endodontics is all about failures. You accept your failures and you move forward. There's another question. It's the same, Dr. Nair's continuation of the same question. It says also, what is the rationale for a new classification? I mean, what added benefit it is providing over the existing systems in the practical aspect and the clinical perspective, or is it just academic?
No. I already mentioned, before the talk, just to add up to Dr. Saiyed's discussion, that definitely the rationale is that to make easy for all, including the clinician or the practitioner, easy for the academician, study for the students, study easy for the curriculum as well. Now we are working on that. I had been to India recently. I had given some almost 10-15 lectures. We are working on implementation of the new system into the curriculum. A lot of reasons. First, interdepartment communication, to be on the academic side and the clinical side as well. I'll give a broad idea. Interdepartment, like many of as we know, we have done videos from India. The patient comes from oral medicine department to the cons and endo department, so on and so forth, other department as well. So the communication, first of all, the communication, you may miss the doctor concerned in the oral department may take it a different classification. When it comes to the cons, it may vary, because again, as with different types, and to remember all the types, you tend to have a variation in the morphology. So it becomes easier. A single code, single verification, what you see, it becomes easy for the operator from the department to carry. First thing. Second thing, I'll just give you a basic idea, basic presentation on that. We do have a supplementary type for accessory canals, anomalies. We do have it, but as the first talk, I just gave a basic new system. I did not talk about the supplementary type to it. We do have supplementary type wherein we classify accessory canals. We classify the two anomaly as well. So again, documentation. Second thing is documentation. You can document all these things. A single code will tell you about the tooth and the root anatomy of the tooth, the variation in the tooth, the variation in the canal morphology, the variation in the anomaly. If the tooth has got some anomaly, that can also be given as a supplementary code and can be documented easily. So in the clinical practice, as Dr. Saiyed mentioned already, the aim, the opportunity to make it, to achieve good prognosis, to overcome the failure, and we are working on micro CT to implement it in the clinical side. Hopefully, I can come up with some results, some output. We'll be sharing with the group sooner or later. So that's how it is rational, easy, and the proper way of communication, proper way of implementation in clinical research and academic as well. Hope I could answer the question.
Dr. Saiyed, do you want to add anything?
No, I think that works perfect. I think we are clear.
Brilliant. Dr. Gausi has asked a question. She's written, seems quite a task. Any such classification system for deciduous teeth in near patient?
There is, I think there are papers. Yeah.
We do have, and there are already published paper on this. As I mentioned, I told you, it's a basic, I just kept it to the only new system. I did not talk about the variation, the other type of classification we have. We have supplementary types and all. We do have it. Like, if I need to go in detail, I may need some 4 lectures for this. So I tried my best to make it short, to keep it to the GPs, practitioners, endodontists, to all the levels. We do have, Dr. Gausia. Yes, we do have a type, and there are a lot of papers in Egypt population and all, and there are few more working. I'm working with them on deciduous in Indian population has been done. We do have supplement for pediatric as well.
Brilliant. So I think there's one more question. How exactly does one really appreciate these classification in conventional intraoral periapical radiographs? Can these classifications?
That's what the question goes with Dr. Ali. Exactly. Again, back to it. Fine. I know conventional. It's about our exposure. If you ask me, even I may not advise any of my patient to go for CBCT directly, until unless it's required. It's required. Suppose if I'm working on a particular kind of a group of populations, like a Malaysian population in my region, okay, I have all data with me. I have to be cautious because they have shown a lot of variation in especially lower anteriors. So if I found there is a variation in the canal or possibility of a missed canal which can lead to a failure of root canal treatment, I could not take a chance of it. I may advise in such patients to go for CBCT. first of all. Second thing, we still stick to conventional radiographs. We may change the angle, different angulations, try to find out the variation by repeating 2-3 IOPAs rather than going for CBCT. But I don't know how exactly, because it's been 10 years, 12 years plus I left India. I don't know how they exactly following in India. But now if you see how, academic side on the hospital side, it's quite normal to go for CBCT, because it's not only the root canal treatment or not the restoration. Patient come in for the overall, they come for implants, they come for other treatment, prosthesis and all. So soon or later, some or the other department may need CBCT for their evaluation or the pre-surgical plot, so on and so on. So it's like for us, it becomes quite easier because the patient comes with you with the CBCT in hand. It has been advised already with some other treatment plan and all. We don't have to do it only for our root canal treatment, as in, right? If you ask me again, I agree. Only for root canal treatment, for a single trip, I may not advise to go for a CBCT.
I think if I have to add a little bit, I think the modern CBCT machines where you have the facility to take 3 by 5 millimeters, the size of an IOPA or a long con periapical radiograph. I think it's exposing a patient to 3 of those simple radiographs. So actually, if you notice anything complicated, let's just say you're taking a radiograph and you do notice something complicated. I mean, this, I think Dr. Saiyed could add a bit more on this. Let's just assume you've seen root canal morphology where in the middle of the root, there is a faint, loss of canal. So you would suspect there's a split. There's probably a second split there. So you might have to take an extra X-ray with a different angulation, which may not give you, added information. So then you probably might refer for this small CBCT exposure. But I think in future, CBCT might probably become a pre-op tool for most root treatments and most endodontics. Dr. Saiyed, sorry, you can add some.
No, for me, if I wouldn't rather agree going for CBCT for almost every single case, because, we get quite enough of information from the 2D X-rays that we have. So we don't need the patient to undertake, so much of unnecessary exposure. Only and only if it is required, yes, I would go ahead. But otherwise, if I see that, I expect that there is canal splitting midway, I would rather, use magnification than exposing the patient to CBCT until and unless it's needed,
Yeah, good magnification can never be ruled out. I think that's a fact. I think a microscope is essential.
Yeah, loops, yeah.
Yeah,
it is adding to our benefit for us, ergonomics. We can see what we are doing rather than, we don't have magnification and we are sending the patient to CBCT. It's not fair enough, I feel, because the magnification is going to remain with us. So I think that would be a better option. If I have magnification versus CBCT, if magnification is helping, then I wouldn't send the patient for a CBCT.
Oh, that's true. We've been having this debate. I've had a few colleagues from Ireland as well. We've had this constant debate about CBCTs.
Dr. Ali, I could add that even nowadays the standard European standard says that even a pregnant lady, she can go for CBCT in that case, But yeah, being on the clinical side, we have all the rights, As I mentioned, I go with Dr. Saiyed. Fine, yeah. If you can negotiate it, if you can go with other. I'm working on a clinical evaluation now, wherein we can see the difference between the exposure and the clinical implementation of it. Again, using a new system. Hopefully, I can come up with some data I can share with Dr. Ali and Dr. Saiyed regarding this.
Oh, it would be nice.
Depends on the operator to operator how it is. But I agree with both of you. Here, CBCT is even allowed in a pregnant lady. And there, if you can negotiate it with the 2D, sure, go ahead. No need to expose patient on CBCT.
Yeah, if I have to put it simply, I don't think we had any issues when there was no CBCT before. I think even if you look at root treatments now, I think there's a trend is going towards minimum taper from 4% to 3%,
4 to 3%,
6-8% taper. I mean, I don't know why we were sticking pro taper next inside the root canals. I mean, this is the trend is changing. You're sticking to 4%.
4% since ages. Immediately after I passed out, since 2014, when I started working, I was never satisfied with having broad canals and stuff. So from then itself, I have been using 4% taper files mostly.
No, but that's good for you. That's really good for you. But I mean, there is a guidelines for of course, the European Society of Endodontics guidelines to implement when you're meant to use CBCT. I think we posted it quite a few times in the GDP group as well. As you said, I think it will I mean, I'm hoping that newer machines come down with reduced dosages, and CBCT could be a tool. But as again, use it only when
that will
required.
take still probably a decade.
Probably, yes, you're right. You're probably right. You're probably right. Let's go back to the next question. How does one really appreciate these classification in a conventional IOPA, which we just discussed? I'm pretty sure. Okay, few types can be, this is from Nadeem Ahmed, few types can be well appreciated only post-obturation. So how one can define these in pre-op X-rays? I think we just spoke about it as well. I'd like you guys to add some. How do you appreciate it pre-op X-rays, the anatomy?
From the 2D dimension, see, there are things which definitely we do not see. But when we are doing our cleaning and shaping and we are activating our irrigant and stuff, we are cleaning those tiny little complexities which we cannot see. And that definitely, if we have done a good job with our cleaning, we see it only post-op. So this is, something which we cannot deny, that we cannot predict everything because we are mostly depending on a two-dimensional radiograph. So yes, there are things that we'll see post-op in our obturation. Like most of the apical deltas and stuff, which I just love, I end up seeing them post-op mostly, not on my two-dimensional pre-op picture, or even with my magnification when it comes to the apical third and stuff.
I mean, if I have to add, the only time I get excited is seeing the cauliflower pattern at the end of the apex. That's the only time I like cauliflower. Brilliant. Shall we go to the next one? It's again from Nadeem Ahmed. Sorry, this is from Dr. Nair. Alhamdulillah, we have a new system from you. Can we know what investigating modality your system was based on? I mean, was this just tooth sectioning or any other methodology? I think this is for Dr. Karobari.
Yeah, it can be used. As I mentioned earlier, there are a lot of interventional techniques in research, sectioning, staining and all. Anything. You can use any of the source. You can use conventional radiographs, CBCT, micro CTs as well. But as I mentioned, again, the clinical information varies as it goes to CBCT and micro CT. Now, we have so many discussion on CBCT, so you can think about micro CT, right? So micro CT is completely on in vitro. So we do have a different, it's just a classification. You can use any of the modalities, best depending on your the research environment, the thing you have it with you in vitro or in vivo or clinical in vivo, you can.
Brilliant. Do you want to add anything, Dr. Saiyed?
Sorry?
No, perfect. We are good.
Dr. Gauss has asked the same thing. We just probably discussed it again. So does microscopes and binoculars help appreciate better the new classification as well, along with CBC? So I think basically it's the same thing we discussed, but
I'm working on it. Hopefully the data comes out, I can share, hopefully, inshallah. I'm working on that clinical implementation of it using microscopes, direct vision, indirect vision. I'm working on it.
Brilliant. I mean, scopes, I think, should be a tool, I think, for every undergrad. It was one of your surveys you posted on the group, wasn't it? Dr. Karobari, was that?
Yeah, from Dr. Karobari, yes.
Survey,
I think
of,
I think we should start teaching operating microscopes up from undergraduate level. This is my opinion, by the way. Shall we go to the next question? I think Dr. Basha has said, does malocclusion have any role in the variation of root morphology or root canal morphology? As we see the Oriental population having some class 3 malocclusions.
We do have variation. We found a variation in relation to gender, age of the patient, and ethnic background. Malocclusion, as in like it's a different entity, comes to the different department, orthodontic. But study has been done specifically some maloccluded patients or maloccluded population wherein they have seen any variation in relation to the malocclusion. No, there are studies we have seen the symmetry on the compared the left and right. Okay, they do have on gender, they do have on age, different age of patient. As the younger have shown the more variation compared to the older patient. Ethnic background, yes, ethnic background have shown the variation. But to the best of my knowledge, there no study has been done wherein they show the relation between the malocclusion and the root canal morphology, as in.
Usually, I'll just like to add, I think this is what I have seen clinically. It's not the malocclusion, I haven't focused on that, but if in one patient, if you have complex anatomy in one of the premolars or the centrals, the lower anteriors or something, you can expect it in the other one as well. So it's not just like, that is what I have noticed. But as such, malocclusion stuff, no.
Yeah, but I know symmetry. You're right. A lot of studies has been done where they show the variation in symmetry as well compared to right and left and gender, age. I know that. But yeah, even I heard first time that something a relation between the malocclusion could be with the internal anatomy. I don't have idea about it.
I'll be very blunt. I don't think that's going to. I think it's probably maybe if you look at the Oriental population, and I think we've come across those lower drastic sevens with C-shaped and multiple anatomical variations, especially in the yellow race and probably the Mongoloid Turkish race as well. But I don't think malocclusion per se would cause or would give you any idea about the root canal morphology, especially, complexities and variations, if I'm not wrong. I'm assuming that concludes the question. Would you like to add anything else, Dr. Karobari?
Regarding, sir, come again?
Well, would you like to add anything else to your talk today?
No, that's it. Go ahead with the questions. No other questions?
I think we've concluded
done with
the
questions.
We're done with questions.
We have covered the topic.
We are open for any other discussions. Like if someone wants to ask what after post-graduation or after undergraduation, Dr. Ali is from UK, all over, they can help out for the UK. Dr. Saiyed is here to talk about Middle East. If you want to ask something regarding to post-graduation, I'm available. We're open.
There's one more question coming to Dr. Karobari. I think Dr. Ali is going to bombard it.
Okay, so this is from Dr. Gaussias. He says, so what my takeaway point today is, magnification and rubber dam are the most mandatory for good endodontics. So how do you define that? Magnification, of course, I agree.
Yeah, the rubber dam, okay, this is a different thing, there is variation or no variation, you need to form.
That is one whole together of another topic we should keep for another webinar, maybe. Isolation.
No rubber dam, no endo. That's
no rubber dam, no endo.
No endo, exactly.
No rubber dam, no endo.
No, exactly.
I end up with so many, I end up with conflicts with so many colleagues sometimes on this.
I agree.
Oh, yes.
Even the undergrads here, like for us, it's compulsory. Even undergrads, they follow this, Even a normal restoration, they just follow first with the rubber dam, then they so on. So isolation is a different thing, actually.
I think there's no excuse. You need to use rubber dam.
No excuse for isolation, sterilization. Especially now, COVID SOPs and all is must. We have different cabins. They made different cabins in the clinic now. They have isolated cabins. It's only for the patients going and the treat. They need to isolate.
Absolutely. Dr. Nadeem puts forward a question. So it says, during your PhD tenure, what classification was encountered more? Dr. Karobari.
Sorry, come again.
The question is, during your PhD tenure, what classification was encountered more? I presume I think he's asking whether you saw Vertucci's or you saw the most recent classification, but you can read the questions if you're able to access the.
Because the thing is the window. I have so many windows here.
Okay, which type? He's just clarified which type of classification.
Type. He means the type. Okay, he means the type. Okay. Commonly, especially in anteriors and all, we find type 3. It's 1-to-1. It's like quite normal. Usually type 1 is very normal. Followed by, if you want to talk about the variation, if you see only variations, yes, we do find different variations. In anteriors, we found some 4 roots, 5 roots with 4 canals and 5 canals in upper molars. Variation could be a lot of variation, but this is the usual thing you have it in Malaysian population, but so do in Indian population as well. If, as per my knowledge goes to all the research I've seen in Indian population, this is the common thing you have it.
I have a question.
Sir,
do they take wisdom tooth into consideration when it comes to making these classifications?
Anything, any tooth. As I mentioned, any tooth. But in case of wisdom tooth, they don't consider it.
Exactly.
We don't root canal treat it. It's just to see the sunshine.
I think all these classifications will be obsolete if they take the wisdom tooth.
But root canal treatment, yes, should be done.
Of course.
If you ask me,
if it is a functional,
we respect all the tooth, irrespective of it being third molar. But classification could be any tooth, not in third molar.
If it's functional, if not, I send it to the surgery department for extraction.
Sorry?
Only if it's functional. If it's functional, I meant if it's functional.
If there's no post-operative, usually any of the tooth, if you see, it cannot be restored following root canal treatment, will you feel that you go for root canal treatment? If it cannot be
No. And that's the priority. If you cannot restore it, no endo.
Same to the third polar. If it is useful for us, it can utilize due to the life. Treat it, inshallah.
Yeah, thank you. Dr. Gaushi has just added to my query when we spoke about classification for wisdom tooth. What about supernumerary tooth? Was that added? Was that taken into consideration in this classification?
Anomalies, we do have a supplementary type for anomalies as well. But again, the question comes to distal molar, post third molar. I don't go with it. But yes, we do have supplementary type for anomalies, and we do have supplementary type for the anomalies in the tooth is as in external canals, and we do have supplementary type for it. We can add to the existing code.
So developmental anomalies like macro and micro.
Exactly. Yes.
Okay.
We'll add to the existing.
So this is
code.
part 1. Part 1 of this lecture. Part 2, 3, 4 coming.
I'll have to make more coffee for that. But it's been wonderful. I think we can conclude, if I'm not wrong. I haven't seen any more questions coming forward. But thank you so much, Dr. Karobari.
Thank you so much.
Sorry,
it was great.
We've got
your time. It's pleasure
sorry, just a moment. I think I'm sorry. I do apologize. There's one last question here. It says, how do you put your classification in dense invaginatus cases?
Yeah, same. That's what is
it's developmental
we add supplementary type to the existing code. The same question.
Perfect. But thank you, Dr. Karobari, and thank you, Dr. Saiyed.
Thank you. Thanks a lot.
Thank you so much.
It's been a pleasure.
Saiyed, thanks a lot. Thanks a lot. I think it's quite early for you there.
No, it's perfectly fine. I usually wake up by 9, 10, so it's fine.
Oh, brilliant.
Oh, I
thought I was the only earlier one.
The time difference is more. 2.5 hour difference would be quite early sometimes.
Yeah. No, I'm still yet to go for work at 1 o'clock, so it's just 10 o'clock here. So I still have.
Oh, you're working for you, right? Working, right? Even mine is working today. Today is my first working day. Here, weekend is Friday and Saturday. Only in these 2 states. Kelantan and Telangana is a Muslim state here, though they have weekend on Friday and Saturday. Today is the first working day here as well.
Brilliant. I'm not working, so I'm going back to bed. Thank you so much, both of you.
Good night.
Thank you all, and
thank you so much, everyone.
And thank you all the participants for joining us in this wonderful talk. But have a lovely day or at work, and both of you, and have a lovely evening. Bye bye.
Thank you.
Bye bye.